Okay, so welcome to this first evidence session of the ARMA MSK Health Inequalities Inquiry. We know that the incidence of MSK conditions is not equal. Inequalities related to age, to sex, to ethnicity, to social and economic deprivation. There's a whole range of ways in which there are inequalities in MSK health. And this inquiry is focused specifically on inequalities and deprivation. So we're currently gathering evidence to produce a report. The report will be completed at the end of this year and launched at the beginning of 2024, which will be the start of phase 2 of this project, which is about disseminating that report and trying to get some of its recommendations implemented. I'd like to thank Grunenthal UK Limited, Pfizer Limited, Novartis Pharmaceuticals UK and Janssen, who have all supported this project through charitable grants, but have had no say in any aspect of the project. The reason for today's session is that in our evidence gathering, we have got some quite polarised views on the subject of self-management. For some, enabling self-management is a way of improving inequalities and driving greater health equalities. Others see it more as something which disproportionately benefits people with agency and good health literacy, and is therefore at risk of widening inequalities. So today we're going to hear from two people with extensive expertise in self-management and long-term conditions to help us unpack some of these differences and debates. So it's with great pleasure that I'd like to introduce Chloe Stewart and Jim Phillips. And I'm going to ask you each in turn to introduce yourselves before we start the questions. So Chloe, could I ask you briefly to introduce yourself and your interest in self-management?
Absolutely. Thank you so much, Sue. Hi, everyone. I'm Chloe Stewart. I'm a health psychologist, and I have a role with NHS England as a national clinical specialist advisor in personalised care, but I work very much within the MSK programme at NHS England. So I am a health psychologist. I've had a long-term interest in how we support people to self-manage, how we support people to change health behaviours, but not just in isolation. I think that actually how we support services to implement supportive self-management is not just about focusing on people themselves, on patients themselves, but also creating supportive cultures, thinking about the training and support for our workforce, and also thinking quite carefully about the services that we commission. And before I hand over to Jim, just to say that I am approaching this evidence review as a health psychologist. So while I do work for NHS England, the views that you'll hear me talk to today and my responses are very much my own as a health psychologist working in this space. So over to you, Jim.
Hi, thanks, Chloe. So my name's Jim Phillips. I've got a background as a psychotherapist and health coach specialised in long-term health conditions. My experience with supported with self-management goes back to the 1990s, where I worked quite closely with what was then Arthritis Care on the development of a challenging arthritis programme, and then went on to lead the rollout of the national NHS expert patients programme as well. Trained at Stanford University, worked both in Australia and the US and Europe around developing self-management approaches, and have continued sort of over the last 20, 30 years on the design, development and implementation of different programs, including sort of work for people like the Health Foundation and others. I also have employment with NHS England, but I'm also an executive director for the Centre for Empowering People and Communities. I sit on a number of working groups for the International Health Literacy Association and various other sort of advisory roles with a number of European healthcare providers, etc. Also, like Chloe, although I have a substantial post with NHS England, I'm talking here very much in my sort of personal expert capacity and drawing on that experience as opposed to necessarily what is a formal NHS England policy in this area. Okay.
That's brilliant. Thank you both very much for that. So before we get started on the debate, it's probably a good idea to be really clear what we are talking about here. Chloe, perhaps I could start by asking you, how would you define self-management?
Well, I think self-management, well, I know self-management is something that people do every day, and what that looks like and how that translates into people's daily lives is very individual. So everybody gets up in the morning, and so self-management is something that people do. And I think what we're talking about today is supported self-management. And this is really about what health and care professionals do to support someone to self-manage, to increase their knowledge, skills and confidence in their ability to self-manage, but to have a partnership conversation. And I think that's key. So supported self-management is not about giving people information and advice on its own in a very paternalistic, didactic way. Supportive self-management to me is the coming together of two or more experts. So the person with an expert of themselves in terms of their life, their wider social circumstances and what matters to them, and the healthcare professional who might or hopefully has a really good understanding of their condition or conditions. And it's that partnership conversation, that goal-orientated conversation, the goal being what that person wants to achieve, what matters to them, and the healthcare professional supporting them to achieve that.
Thanks, Chloe. Jim, is there anything you wanted to add to that?
Yeah, probably just add in two other things. One, in the literature and also in approach, we separate self-care, which is generally defined as more of a day-to-day activities around just generally sort of staying well, brushing your teeth, the counter medicines, taking ibuprofen for a headache and that sort of thing, managing coughs, colds and everything else. And self-management, which tends to be specifically defined around the tasks you need to undertake to manage a long-term health condition, such as MSK conditions, for example. And exactly as Chloe said, supported self-management is then the activities that the healthcare system can put in place to help people improve their confidence, knowledge and skills and ability and capability to manage that long-term health condition.
Brilliant. Thanks very much. That kind of sets the context of what we're talking about. So one of the things that has been said to us in the course of this is that there's a concern that self-management can come across as blaming the individual, and one person with lived experience put it to us. They said, it's code for you're on your own. Is there a need in this context to kind of reframe self-management? Jim, do you want to start with this one?
This is a really, really interesting area, and this is a societal issue probably, where we tend to, if we're not careful, tend to have good health behaviours and bad health behaviours. Given, obesity is one area where that debate is very strong on how that is viewed. You could say, likewise, other activities, it's perfectly okay to go skiing and completely wreck your knee, but it's not okay to potentially sort of have other sorts of behaviours. It's definitely not about being on your own. I think the key here is the responsibility or awareness of healthcare providers to recognise people with low health literacy who are struggling to manage their long-term health condition and ensure that the appropriate support is put in place to enable that to happen. So it's definitely not about being on your own about it or blaming, but it is back to the heart of a conversation which Chloe alluded to, the conversation between the healthcare professional and the patient around, in terms of outcomes, what are the most important outcomes for you, taking into account your current life circumstances and where you want to be and what is most important to you. So that might be outcomes around being able to continue to work, maintain independence, interact with your grandchildren, keep up a social life, be able to go on holiday. So a whole range of things which aren't necessarily clinical outcomes, but are of the highest importance to the individual. And that's how that support should then be orientated.
Brilliant. Thanks, Jim. Chloe, is there anything you wanted to add to that?
Yeah, again, like Jim, I thought this was a really interesting question. And I think in my experience, there is mixed ideas, mixed views about what self-management means and what supported self-management means. Often, when I work with services and providers, self-management is viewed as giving information and advice. So it's often providers spend a lot of time thinking about the information that they might want to give to patients. So in MSK settings, that could be around exercises that that person might want to do, or information about their condition. And I think just to add that we know that giving information and advice is just one part of self-management, but actually behaviour change is much more complex than that. And information and advice on its own, as we all know, because we all, I'm sure in the past have tried to change health behaviours or think about the things that we do in our life and things that we could do differently. And just knowing what we could do doesn't translate into behaviour change, because it is also about thinking about that person's capability, their opportunity as well, in terms of their, ability and their motivation, in terms of their ability to change behaviour. We need to think about habits, and lots of the things that we do as individuals are automatic, they're unconscious. So we can know a lot about what to do and why to do it, but not be able to translate that into practice. So the evidence shows that really having helpful conversations with people, underpinned by a kind of coaching approach, a health coaching approach. Some people might have heard of motivational interviewing before. So having a partnership conversation with someone, eliciting their own motivations for change, really understanding their goals and their ideas for how they might translate that into practice, is going to often be more helpful than providing that person with unsolicited advice.
Great, thanks. And we've had a good follow-up question to this one in the chat. So you talked about identifying people with low health literacy or other reasons why they might be challenged by self-management. What methods do you think health providers can use to identify the people who really need this level of support?
That's actually quite simple. There's two. You can go down the route of questionnaires and all the rest of it. Personally, I think is to ensure that all healthcare professionals are trained in core skills such as health coaching. And then if you structure a consultation using shared agenda setting at the start of a consultation, towards the end of a consultation, if that consultation leads to the patient having to take on some sort of activity or action, just quite simply asking them, thinking about what we just talked about, how confident do you feel you're going to be able to follow these exercises, make changes to your diet, or do this, or do or whatever it is. If a person says not very confident, that clearly indicates that they need additional support. So there's various ways you can structure consultations, and there is training around this, evidence-based training available. The Personalised Care Institute provides e-learning on this to healthcare professionals to very easily within that conversation identify people's levels of health literacy, and using health literacy skills such as chunk and check and teach back. So we've talked about a lot of quite complex information today. I would like to just check whether, that we both heard the same thing. Could you just talk me through how you would explain what we've talked about when you get home to another person, for example? So there's a whole skill set around doing this in a way which isn't condescending, isn't about questionnaires or anything like that, but is actually embedded within the consultation.
Great, thanks. Chloe, did you have anything to add to that?
Absolutely. I think just advocate really for what Jim has said. I mean, I do know that there are MSK services that have used in the past the patient activation measure, known as the PAM, to really ascertain that individual's knowledge, skills and confidence. So that is a licensed measure, but there are other measures if you did want to go down the questionnaire route alongside supporting your workforce to have those really good health coaching, what matters to you conversations. But there are other measures that you can find on our Futures platform that are free. And you might start to use those to start to stratify, or not even to stratify, really just to get a different level of understanding of the people and the patients coming into your service. So I would see that as supplementary information to the conversation that's had in the clinic. I would think that it wouldn't be possible to start to segment people without having that individualized conversation.
Brilliant. Thank you both very much for that. So we've had a lot of evidence around self-management that uses language like advice for self-management. Somebody described the sort of thing you're talking about as not the usual NHS self-management. So it seems to me that what the NHS is doing at the moment with under the label of self-management in a lot of cases is not the same thing that you're talking about. What do you think we can do to move things in the right direction? Chloe, do you want to start with this one?
Yeah, so absolutely. I think there's varied understanding of what supported self-management means across kind of MSK settings. I do think that there's some really good examples of fantastic work that is happening. So we know that there are 3 evidence-based interventions that are like self-management interventions that are likely to have a real benefit for individuals, but also be really cost effective as well. And especially important for people living with multiple long-term conditions. So they are health coaching, so access to health coaching, access to peer support. So there's a lot of evidence to show that people living with conditions can support themselves and other people as well. And self-management education. So we do know that there are some providers, some MSK providers that are utilising one, if not more, of those interventions to really, really good effect. But I think you're absolutely right, Sue, that's probably not consistent across the country. And one of the things we have done, and it will be published any day on the, well, not published, but put up on the Futures platform, is a guide to supported self-management in MSK settings. So that's a guide to, it's not meant for patients, it's a guide for anybody who's working in an MSK setting who would like to think about how they could enhance their supported self-management offer. And it's a toolkit. So you don't have to read it from cover to cover, but you can start to think about what things have you got in place already, and where are the areas that you could look to expand on or to develop further. So that is due to be published. I've been saying any day for a long time, so I think Sue might gasp in horror, but it is finished. It's been co-produced with people with lived experience as well as clinicians, and that will be available very shortly. What is available now is a lot of information around supported self-management on the NHS England webpage, and I'll pass over to Jim because I'm sure he was involved in developing that and might have some other useful resources.
Yeah, I haven't got a huge amount to add, but you're right, there is huge variability around access to one, structured self-management education, sort of 6-week courses of that sort of thing, health and well-being coaches, etc. I think we are going in the right direction. I mean, this sort of support has sort of, you know, waxed and waned over the years, you know, with different sort of priorities, different governments and different sort of funding structures. But I think we're probably in a better place now because, you know, with health and well-being coaches within primary care, which are sort of now sort of core funded as well, and that funding is in place through the direct enhanced services framework in primary care. Those health and well-being coaches can, one, provide tailored one-to-one support to people. They can run self-management courses. They can help support peer support groups and that sort of thing. And likewise, of course, one of the key things which impacts on people's, we all know that if you're feeling stressed, if you're feeling anxious, if you've got other things going in your life you're worried about, one, it makes managing your health even harder, particularly if you've got if you're a carer or you're a parent and anything else, you're obviously putting other people's needs first quite often. So social prescribing link workers are also a key resource now in the NHS to help people where they've got issues such as housing, debt, loneliness, and these other factors which can really impact as well. So, between those roles, health and wellbeing coaches, social prescribing link workers, and also care coordinators, there is now much more dedicated support than there used to be, particularly in areas of higher deprivation and things where some of the sort of opportunities to manage your health are far less, i.e., if you haven't got much money, if you haven't got access to the right sort of food, haven't got access to green space to sort of exercise and get fresh air and things. So social prescribers can really help with that, and health coaches can really help people think through what their long-term goals are and support them to develop the skills and confidence. So we are heading in the right direction, and theoretically a lot of those structures are now in place, but the issue there is now improving access and making sure that the right people are accessing those.
Okay, and there's a question in the chat that sort of links to that, making sure the right people bit. So is there a risk that NHS services attract those with higher health literacy and capability to self-manage? And should services be reaching out to communities on the basis of determinants of health and health literacy? So you talked about identifying individual patients, but is there also a role for reaching out to communities? Any thoughts on that, either of you?
Yeah, absolutely. So we've got something called proactive care and proactive or social prescribing. So that is really proactively identifying those people who are either struggling or are at risk of struggling, so we know that they might be socially isolated. We know that they might be in accommodation which isn't ideal. We know that for various reasons they're using NHS services more than you would expect, quite often because they are anxious, they are worried, they are finding it difficult, and therefore they're not getting the right support at the right time. So that proactive outreach is really, really important, so that we are getting those people with the highest need and sort of driving it in that direction. There's quite a lot of literature on this, and it is an approach which we're really advocating and pushing within NHS England as well. So it's like, how do you really identify those patients who are most at risk of just finding it all too much? Yeah.
Chloe, did you have anything to add to that?
Yeah, well, just to say that I think all systems, all ICSs are thinking about developing their maturity around what we call population health management, and that is really looking together as a wider system, not just thinking about health, but to gather data to really start to identify those communities, those neighbourhoods that most need support. And as they mature, those population health management abilities will get better and better, because it won't just be about using quantitative data, but also layering that with kind of qualitative insights. And I think what will be really important is that when we start to identify perhaps communities or individuals of people, cohorts of people, that maybe their needs aren't being met. So it might be that they're overusing healthcare services, or perhaps not even walking through the front door of any services, that we can start to co-produce some interventions, for want of a better word, but something that's going to work for those people. So I think really utilising the methodologies of population health management, but then looking to co-design the what next with those people who are going to deliver that service and those people who are going to be impacted by that service, so that we're not thinking that we necessarily know what's going to work for them. So I just really wanted to highlight that co-production and population health management will be really, really important when we're thinking about those people whose needs are currently not being met.
Brilliant, thanks. There's been a question about, can we share a link to the toolkit when it goes live? Oh yes, we will all be so happy that it's gone live. We will be sharing it everywhere. But the Futures site has been mentioned a couple of times. So just to explain, NHS Futures shares all sorts of resources. It has a whole series of different work streams, one of which is the Best MSK Health work stream or workspace. You have to register to get access to Futures. If you don't have an NHS email address, you are not excluded from Futures. This is really important, but you do have to email and say why you want to be part of Futures. But anyone who can explain why they need to be part of Futures can access it. And then you additionally then need to say, and I want to be part of the MSK workspace. So it's a sort of two-stage: register for Futures and then register for the MSK workspace. But that is where things like this toolkit will be shared, and we can share things that are more of a draft and take comments on them rather than them going through the official publication and then being set in stone. So anyone who's not already registered on Futures might want to just register for Futures and for the MSK workspace, because as soon as this toolkit is up, it is going on the Best MSK Health one, isn't it, Chloe?
I'm not sure, actually.
Okay.
Yeah, it might not go on the Best MSK Health one, but I will let you know exactly where it goes.
Okay.
Yeah, because it might sit alongside the community framework that has just been published and some other toolkits to support that. But I'll let you know, Sue. I am really hopeful it's going to be available any day. But just to reiterate Sue's point, I think this isn't a published toolkit from NHS England. And one of the reasons for that is because we really want your feedback. We really want to understand what parts of it are useful, what parts of it aren't, if there's anything missing, so that as and when, or if and when we do publish it, it's the best that it can be.
Brilliant. Thank you very much. So one of the other concerns that's been raised with us about this is we know that the areas where the most need is for this supported approach to self-management are also the areas where systems are struggling the most. So you've got this inverse care law where there's actually fewer GPs in areas of deprivation, fewer of everything in the areas where there is the most need for this. So how can we ensure that this supported approach to self-management is implemented equitably when we know that systems are struggling? Jim, do you have any thoughts on that?
I think equity of access is always an issue, regardless of the service, whether it's a clinical service, is access to self-management or anything else. I know someone mentioned about GP access in the chat as well, and the delays there. And I see someone's also just mentioned digital too. For me, we need to ensure that this sort of support is provided in a way based on the conversation with that individual. So if they're happy with digital, then digital, fine. If they want face-to-face, then that needs to be available as well. We need, different ways. And some people start off with one and then sort of transfer to another. I don't really have an answer to this, because I think this is down to very much sort of individual ICBs, integrated care boards, integrated care systems, where they hold the budgets. Is about what they consider is important, and this might involve sort of local campaigning by patient groups to improve access to this source of support and make sure that those systems actually start investing in this sort of area. So there is some core infrastructure through health coaches, link workers, etc., which is nationally funded, and that funding remains in place. But I think a lot of this is going to be sort of down to sort of local debates around how people want their health services delivered and what are the priorities. I might still feel like I'm dodging the question a little bit, but I think it is very much much more of a local issue. You know, it is a tricky area, and I think, you know, we need to keep improving training for clinicians and system leaders around really understanding the implications of health literacy, what it means, what low health literacy means. So this isn't a blame thing and everything else. And if we're working with communities where we know low health literacy is low, then for me, that is not the fault of that is the community, that is the fault of how we're providing systems and everything else, and interacting with those people. And we have to significantly improve it and take the view that if people are struggling to manage their health and well-being, then we have a duty of care to ensure that they have access to the resources to actually be able to improve their confidence, knowledge and skills around that. So it is around access, it's about broadening access and just working really hard around that. You know, we do have methods around this. It's like, you know, making sure that, you know, peer groups and things are, you know, really embedded in local communities, you know, sort of local mosques, churches, that sort of thing involved, sort of men's sheds, sort of gardening, allotments and all that sort of thing is all brought in as well. This is broader than health. This is about sort of how communities function and how communities are empowered to, you know, have a say in what their environment is like, have a say in what sort of services they have. So this is a really broad issue. There's a whole movement called the wellbeing economy now, which is looking at how do we empower communities, local government to really think through what sort of economy, what sort of structures do we want in place to promote health and well-being, which is more than just money, more than just sort of finances and things. So it is a huge question. It's a huge question.
Thanks, Jim. Chloe, I don't know if you wanted to add anything or to comment on the question we've had, which is I think sort of linked. So in a system where patients can't get access to a GP appointment, long delays in accessing services, how can we make sure that people understand that we are doing this self-management approach because it's been shown to be beneficial, not because it's a way of getting people to do things that the NHS would be doing otherwise?
Yeah, so I suppose my immediate response to that is co-producing solutions with local populations so that they're really involved in the co-design and really involved in deciding what the success measures look like for that. Because I think if we start to co-design services with people, in partnership with people, everyone will know what those services are trying to achieve. So that feels really important. I think just to build on what Jim was saying, I think another thing we have to think about as systems, as ICS systems, but as NHS England, how do we measure success? You know, some of the outcome measures that we have within commissioning frameworks don't really look at personalised health outcomes. What they look at is very much process metrics. So how many people were seen in the service as a proxy measure of success. And we know that there are some fantastic pieces of work. So if anyone's interested in this area, Greg R. Smith, who's the Chief Medical Officer in Scotland, is starting to really think differently about the way that they measure success across Scottish health services. And I do think that really thinking carefully around outcomes, and really making sure that we include patient-reported outcome measures, thinking about people's quality of life, will be really important when we look to make changes at a local level. Because if we could really start to measure the things that matter, I think then there would be further investment in things like supported self-management, as Jim and I describe it. So, you know, systematic investment in access to peer support, health coaching, and self-management education as well.
Brilliant, thank you. And an interesting question in the chat. So we've talked about the fact that making sure that this is equitable and this is delivered well is a local ICB issue, but have either of you got any thoughts on what might be national level policies that will support those local systems to be able to do this?
I don't mind starting, Jim, if that's helpful. I can start from an MSK perspective and then hand over to Jim. So we recently published a community framework for the recovery of MSK services. And in that, supported self-management, in the way that we describe it, it features very loud and clear. So that's a really fantastic document that hopefully will support those community MSK providers to recover well. And when I think about recovery, there's lots of things that recovery means, you know, what does, but fundamentally it's access to community services. So really trying to reduce those waiting times. So that's a recent policy document that really includes supported self-management. Another thing that we do is when we're creating what we call kind of clinical guidelines, we make sure that supported self-management is included within those clinical guidelines. So that's not guidelines for patients, but that's guidance for clinicians or service leads, which really make it clear at what point is supported self-management really important. Now, it's really important at every stage, but we know that it can make a significant difference if it's really done what we call upstream. So not when somebody's gone round the houses, had multiple appointments, but it's really something that happens from the very first contact you have within MSK services. So that might be with a first contact practitioner or a GP in primary care, or if we have self-referral now into MSK community services, well, we're building that up. And if someone self-refers to a community MSK service, really making sure that people have access to really good quality supported self-management. But just to say again, this is varied across the country. So we do have work to do to make sure that that offer of supported self-management is available more widely across the country. Jim, did you want to add to that?
Yeah, two things. One, people will be aware there's a consultation, public consultation on the major long-term condition strategy. So, you know, hopefully, you know, people's responses to that will help sort of strengthen national policy. Self-management has been a core part of NHS policy and strategy since the 1999 white paper, Saving Lives, Our Healthier Nation, when the concept of the expert patient was first sort of put forward, and with that, the rollout of the expert patient program. I think it's just worth noting the journey a little bit. So I see Cheryl Berry's on here, who, you know, will remember this. When we set up the expert patient program, I can remember conferences being stood up to talk about it, full of clinicians, and one was the HSJ conference, unanimously saying, this is absolute rubbish. Clinicians are the experts. We've had 6, 7, 8 years of training. How can a patient possibly be an expert? How can a volunteer run a self-management program? Patients, they need to know this, they need to know that, and all the rest of it. You know, that's where we were sort of 20 odd years ago. And I think a lot of those attitudes have shifted in the last 20 years. However, there's still, as we know, an element of paternalism within the NHS sometimes. When systems are pressured, it's much easier to revert back to do to rather than work with, you know, when things are pressured. So we have come a long way, but the key change is going to be the continuing changing in how healthcare professionals see their role in working with patients. Do they see themselves as the fixer, or do they see themselves, as Chloe was describing earlier, a partner in care where you're working together in a partnership around what are the outcomes which are important, which might not always be the optimal clinical outcomes, but they are the outcomes which are important to the patient. We're still a little way off of our way of working being the norm within clinical services. And it varies between clinical services as well. And it varies with a power dynamic too. So if you look at some areas such as renal, where you've got dialysis, where your life is dependent upon that 2 times a week session, you know, so we do see a lot of variation within that. And I think that's the key shift which continues, which needs to happen, so we can have all the policy, all the strategy in the world, all the grand sort of toolkits and everything else. But we need to continue to work around that fundamental shift around how patients and clinicians work together. Clinicians need to develop those skills, and patients need to develop that way of working as well. It's often undermined by the media, the way sort of treatments are put forward. You know, another fix is going to come along. You don't have to do anything. There will be a new drug at some point, a new operation. So we need to change that whole conversation. And this is why there's a whole piece of work called Better Conversations, which really looked at, this is about improving the quality of the conversation and the quality of that partnership. So it's tricky. So for me, if I look around, there's loads of policy on self-management. You see it everywhere, but we got to ask the question, why isn't this way of working being picked up more within clinical encounters and those sort of conversations, both at primary care level and secondary care level, and all the way through?
Thanks, Jim. And this might be the point to bring in another question that's come up, which is, it's great to hear about the healthcare professional training and new roles. And there's been a lot of training delivered to date around personalisation, but still patients are not always getting the support that they need. How will healthcare professionals' competencies be monitored? Because training alone does not make someone a good deliverer.
I'm just going to jump in. So to address this, so one of the things NHS England commissioned was the Personalised Care Institute, which is hosted by the Royal College of GPs. It was set up specifically to ensure access to evidence-based, quality-assured training in things like shared decision making around, and it set out the core competencies needed around personalised care, and it built upon the Health Education England work. And it also set up a system for accrediting training providers as well, so that, you know, a core issue was there is no standardization around this training, no quality control or anything. So that was put in place specifically to do that. It's then been working with the various royal colleges and things, and so you will see now first contact practitioners for, say, physiotherapists. Some of these core competencies are now part of their professional competency framework. So it's part of their ongoing professional development and so on. And we're seeing that in more and more of the professions, but they're starting to build these competencies into the competency frameworks for those different professions. And then, of course, it gets built into their ongoing professional development. There's always, as we know, a slight gap between people's perception of their skills around working in this way and what the patient experiences. And we know that generally healthcare professionals overrate their competencies in this area. And there's a number of studies, observational studies, where clinicians have been asked to self-rate their skills. They've then been observed and the patients have been asked, and there's a significant mismatch between the two. That's always going to be an issue. That's an issue with any training. And we're trying to get smarter with the training. We've introduced some virtual training now, some avatar type training and that sort of thing, which, so there's always going to be an issue. I'm not sure what the answer is, apart from continuing to do what we're doing, really. That's all we can do. But there's now a lot more things in place than there were maybe sort of 3 years ago to support her.
Brilliant, thanks, Jim. Chloe, did you want to jump in?
Yeah, just to talk about an experience I had. I worked in an MSK service in Sussex between 2016 and 2020. And my role there was supported self-management lead. And one of the things, or one of the significant things that I had to do within my role was support clinicians to adopt these skills, these health coaching skills. And I think that was a really unique role. I think it was really well placed by the leadership team there, that recognition that training on its own doesn't change behaviour. And in the same way that telling a patient to do something doesn't translate into behaviour change, just doing a training course and telling clinicians how to do health coaching doesn't translate into behaviour change. So it was a really unique opportunity to look at, the challenges and enablers to supporting the workforce. And just a couple of those things now. So some of the challenges are the way that we've set up services, the very short consultation time that practitioners have. Also, the time that they have set aside to develop their skills and competencies in this area, including time to self-reflect. So I think services providers have to think about how do you invest in your workforce to create the conditions where they can develop these skills. And then just from a practitioner or a healthcare professional standpoint, we all have within us this desire to, most healthcare professionals come into their roles because they want to support people, they want to help, they want to make people better. And that's, if anyone knows much about motivational interviewing, they'll know that that's often referred to as the writing reflex. And it comes from a really nice place, but often it gets in the way of this approach that we're talking about today. So what I would say is, as a health psychologist, I noticed that writing reflex shows up in my daily practice. It also shows up in my relationships that I have at home, especially for those people that I care about the most, so my partner and my children. I often feel like I'm giving them really well-meant advice. So it's really hard to turn off that writing reflex, to resist the urge to give unsolicited advice, and to start to elicit from people their own ideas and motivations. So that is a huge skill. It takes time and practice, and we have to support our workforce, whether that's in early education or in secondary education, whatever their career progression is. But also we need to give people time for reflective practice while they're doing the job, because these skills aren't something that come naturally to any of us. They have to be continually practiced. So that's just a bit to add on to what Jim's already said.
Brilliant, thank you very much. And one last question from me. How can we ensure that things like health coaching and self-management support are culturally sensitive? So the example that's been given to us is things around diabetes and supporting people to think about what their diet and what they eat. But if the person doing that has some really culturally specific assumptions, like a very, very Western or English idea of what a meal consists of, then that conversation can rapidly come unstuck. How can we make sure that what you're talking about is done in a way that is culturally sensitive? Chloe, I don't know if you want to start with this one.
Yeah, well, I'll start and then hand over to Jim. So I think two things is that I know that as primary care networks and providers are employing the additional roles, so health coaches or social prescribers, they are thinking increasingly about making sure that there's representation of the communities they serve. So making sure that they are have people that have a really good idea about those cultures in which they are that they're serving, that they're supporting. The other thing that I'd say is that this comes back to the skill of the practitioner. So not assuming that we know, and I think that's the same, that's really important, and probably more important when we perceive ourselves as being from the same culture as someone else, because even within cultures, people have individuals. So it's that heart set and that mindset that when we enter into conversations, that we start to really be aware of our own bias, that we don't assume that we know, and that we seek to understand that person within the context of their lives, and that includes their cultural background as well. So I think, two things there. There's the making sure that we have a diverse workforce that represent the communities in which we serve, but there's also that that this is about not having the answers, recognizing our own biases and seeking to understand the individual that's in front of us. Yeah, over to you, Jim.
Yeah, so it's all about training, and again, it's starting with a person. So, you would start off with, Chris, talk me through what your understanding is around an appropriate diet for your condition. I mean, I'm paraphrasing there quite a lot, obviously, but is that starting with a person, starting off eliciting what their understanding is around that particular thing, what advice they may or may not already have given, what it is they're already doing, and always starting with a person, starting with eliciting their understanding, what their current knowledge is, what their current beliefs are, and what their current circumstances are. And then you've got all of that information, which also tells you where there might be potentially gaps as well, and then tells you what potential support and where to start from and everything else, as opposed to coming straight in from the, and ideally we would want you to adopt this diet or this exercise or something. So it's flipping it on its head, always starting with a person, understanding where they are, what their current knowledge and everything else is of that particular topic, and then building from there. And that way, you're working in partnership with that person, and then negotiating in a way changes which are appropriate and feel doable by the individual as well, and work for their particular circumstances. Yeah.
Brilliant, thank you very much. So the time has flown. We are approaching the end of our hour. So just to sum up, I'd like to ask each of you in summary to answer the question, what do we need to do to make sure that self-management approaches do not exacerbate health inequalities? Chloe, do you want to start with a brief summary of your key point or points?
Brief summary.
Yeah.
So I think most importantly is that we start where the person is at. So we really think about the needs of that person, not just about their condition. People are not just conditions, but we think about that person in terms of the wider context in which they live. And we seek to understand the things that matter most to them. But then I think what we know from the evidence is that, what people need is information and support that is relevant to them. So we need to think about how the public are enabled to take a really active part in conversations with healthcare professionals. So what do they need in advance of their appointment? What support do they need? We need to think about the training of our workforce and their wider support. We need to think about ensuring we've got supportive systems and cultures in place, and that includes outcomes, systematically recording outcomes that matter. And then finally, we need to make sure that we start to commission services that people want and need rather than what we think they should have. And that isn't something that I've just come up with. If anybody knows the House of Care model, that's really what the House of Care model advocated for in terms of supporting people living with long-term conditions. And that was published some years ago now. So it's really time that we put that into practice and really make sure that wherever people are across the country, that they're supported in the way that's going to be most effective for them and given a range of options to choose from. So over to you, Jim.
Yeah, I would just add in 2 core enablers: high quality shared decision making. So really good quality conversation right at the start around what are the treatment options, including doing nothing, including lifestyle, including pharmaceutical surgery or whatever is appropriate for that particular thing. And that'll then help draw out the person's support needs depending on what option that person moved towards. Also, high quality personalized care and support planning, so that in-depth conversation with the individual around what's important to them, what outcomes do they want to work towards, and then from that, again, being able to identify, so, you know, what needs to put in place to enable that person to achieve those outcomes. So it might be health coaching, might be social prescribing, it might be dietary advice or rehab or physiotherapy, who knows, but it's the quality again of that conversation. So I think those are sort of two key enablers which are already out there but which can be improved upon.
Brilliant. Thank you very much. And thank you to both of you and to everyone who's joined us today. This session has definitely provided some really valuable information that we will be using and incorporating into our final report.